Hello, everybody, and welcome to the next interview session of our EOA connectivity series. We are very excited to welcome you for the big live event Endoscopy on Air on June 4. And in preparation for this event, we have the pleasure to have a series of interviews on behalf of our sponsors. We are very grateful for our major sponsors, and one of them is Micro-Tech, and we want to present their short wire system. To explain very briefly what that is and what the specifics may be, we have brought you a short video which we would like to play, and this is then followed by an interview. So this is the short wire system from Micro-Tech. I especially like the abbreviation SHOW, and this is how it works. You have this part with its inner life shown here, and it's then mounted onto an endoscope, and here the guide wire is shown running through the locking device here, that the guide wire is locked. And in the next sequence, you see a very nice schematic movie with a sphincterotome rounded at the tip. And you see the cannulation process. This is a view we rarely have from inside the bile duct. And then you see how the guide wire is introduced. Sphincterotomy is performed. And then you see here the sphincterotome and the wire released from the system, from the catheter. And at the end of this, two examples are shown. One for stone removal. Here the guide wire is locked again. Here's the stone basket introduced over the guide wire. The stone is grasped. And the other one shows, in a different case maybe, and we'll come back to that later on during the interview. In a different indication, the respective metal stent is set free, also using the same short wire system. Okay, so we want to talk about this a little bit more, and I'm very happy to welcome Mark Ellrichman from the University of Kiel. Hi, Mark.
Hi, Thomas.
And Mark, so of course it's nice and it might make endoscopists' life easier, but what's the actual clinical benefit?
So the main topic of the modern endoscopies at the moment, infection prevention, and especially infection prevention in ERCP. And the question I'd like to raise is, does a short wire system help in the infection prevention in ERCP? So when we talk about endoscopy or about ERCP especially, we have to deal with two different kinds of bacteria. It's the endogenous bacteria on the one hand. These are the bacteria from the oral cavity. And on the other hand, the exogenous bacteria, and that's the real contamination of the contaminated material, like the endoscope, like all the consumables, all the instruments that can potentially lead to a clinically relevant infection, namely a cholangitis, a bacteremia, or post-ERCP pancreatitis. There's a very nice study that dealt with the question of the rate of bacteremia during and after an ERCP, a conventional ERCP. It's the Tosani study published in 2016, and the colleagues draw up to three sets of blood cultures, one baseline blood culture before performing the ERCP, a second blood culture immediately after the end of the ERCP, and a third blood culture in case they performed an additional single operator cholangioscopy. So based on this true positive blood culture rate of almost 30%, the colleagues tried to evaluate special risk factors, and they evaluated patient-related risk factors compared to procedure-related. So the patient-related, that cannot be changed. It's age. So the older the patients are, the higher the rate or the risk is of a persistent bacteremia. And another indication is a large stone. When you encounter large stones, then you have an increased risk of a persistent bacteremia. But the second part of risk factors are the procedure-related risk factors, and that's prior stent placement. That increases the risk. And of note, the whole duration of the procedure. And when you have a look, you have a persistent bacteremia with a procedure time of around about 47 minutes compared to 38 minutes, and then you do not encounter a significant bacteremia with a p-value of less than 0.5. So this delta of 9 minutes, that can make the difference between bacteremia and or cholangitis.
Okay, Mark, very interesting. I think when I was a young endoscopist, we were very well aware that we kill our patients by inducing a pancreatitis, but now the bacteria come up. So what's your recipe? What do you do in clinical practice to keep both risks as low as possible?
We can still kill the patients with a post-ERCP pancreatitis, but I think one key to reduce the risk of infection and to cholangitis is to save time during your ERCP. The one thing is, the more experienced you get, the quicker you get. But I think you can use kind of low-risk ERCP techniques to limit or to lower the risk of the ERCP-related infection. And of course, you have to rely on all the recommended prophylaxis of the post-ERCP pancreatitis, namely NSAR and the prophylactic stent placement. These are the three topics you have to think about. When we have a closer look in what we can do in clinical practice, the most important topic is to carefully think about the indication. If you do not perform an ERCP at all, then you cannot create any kind of ERCP-related infection. And that's one thing Peter Cotton, one of the first inventors of the ERCP from the UK, once said during a live course, ERCP is most dangerous for those patients who do not need it. And that's actually what you definitely have to keep in mind. I think every one of us knows the young lady with a biliary stone. Then you just have to look at the papilla, and she almost gets an acute post-ERCP-related pancreatitis. But there are other things, despite or in addition to the indication, you can potentially reduce the risk of infection, and that's the short wire system. And I will compare shortly the short wire system to the long wire system. And then based on the short wire system, we have two different kinds of ERCP technique. It's the physician controlled technique or the assistance guided cannulation. And on the third place, the wire versus the contrast guided cannulation. That is completely independent of the wire system you use. The data definitely say that we are in favor of a wire guided cannulation to reduce the risk of post-ERCP pancreatitis compared to the contrast guided cannulation. So when we have a look at the long and short wire, the long wire, as the name says, it's long. Yeah, it's just a bit more than 4 meters long, 4.50 meters, depending on the company you use. And based on this very long guide wire, the team communication for every instrument exchange is very, very important. Then the position of the wire from my perspective is not safe. I think we all have the example, you have got a Klatskin tumor with a high-grade stricture. You spend half an hour in manipulating your wire over this high-grade stricture, and all of a sudden either you or your assistant just manipulates the wire and it dislocates and you start all over again. Based on this very long wire, the, well, so to speak, surface of contact is quite large, and that's why you get a potentially impaired hygiene. The time of device exchange is much longer, and that translates into a longer total procedure time with long fluoroscopy, higher amount of contrast, and a higher need of sedation. And then actually vice versa is the short wire system. So we have a short wire, it's almost 2.60 meters. We can perform a single operator exchange by this locking device that's either connected to the proximal part of the working channel or to lock it at the distal part of the endoscope. We have a very safe position of the wire, and the endoscopist is more or less independent of the assistants. And that translates into a quicker device exchange and therefore a shorter total procedure time. One of the rare studies that directly compares these two wire systems in a randomized fashion was the Draganov study from 2010. They had a one-to-one randomization, short versus long wire, in this case using the Fusion Cook system. The primary endpoint was defined as the time of the device exchange, and the secondary endpoints were more the clinical, technical parts: time of stent implantation, total procedure time, time of fluoroscopy, cannulation, and the rate of complication in total. So what they found is, as the primary endpoint, the stent insertion time was statistically significant. 135 seconds in this case compared to 250 seconds. Total device exchange time almost failed to reach statistical significance. When you have a closer look to the total procedure time, is almost 1,400 seconds compared to almost 2,000 seconds. I have no idea what seconds means in minutes. That's why I calculated this for you. It's 23 minutes compared to 32 minutes. And again, we have a delta. Short wire versus long wire in favor of the quicker procedure time, 9 minutes quicker of the short wire system. And keep in mind, exactly these 9 minutes, they came up during this Tosani study with a risk of bacteremia. So probably, though a direct comparison does not exist, we have a quicker procedure and potentially have a safer procedure with the short wire ERCP. So then we come to the next step that is only possible by using the short wire technique. It's the physician compared to the assistance guided cannulation. And what does it mean? The assistance guided cannulation, that's what we all do in clinical practice every day. We have the catheter. Inside the catheter is the guide wire. As an endoscopist, we maneuver the instrument through our working channel into the papillary area, and then the assistant tries to cannulate our target area, either pancreatic duct or CBD. With the endoscopist guided cannulation, you manipulate your instrument to the distal part of the endoscope, and then we already split the guide wire from the instrument, and then the endoscopist by himself can easily manipulate the catheter with the working channel, with the elevator, and in addition, we are able to maneuver and manipulate the guide wire by our own. There's one nice study also randomized in a 1-to-1 ratio that compares the endoscopist control technique to the assistance control technique from 2016. And they had several endpoints. They had 4 groups in total, more or less 55 patients per group. And they had the endoscopist controlled wire technique with a smaller catheter, 3.9 French, the larger catheter, 4.4 French, and the same diameter of catheters with the assistant-controlled wire technique. All the technical criteria like initial biliary cannulation, pre-cut sphincterotomy, eventual biliary cannulation, cannulation attempts, time to cannulation, and fluoroscopy, they were not statistically significant in all of these groups. So that was, from the technical point of view, more or less the same. But when we have a look at the complication rate, That was endoscopic complications in total in these 4 groups, and especially the risk of post-ERCP pancreatitis. The colleagues encountered a significantly increased risk of endoscopic complications and especially post-ERCP pancreatitis in this assist and controlled wire technique with a slightly larger instrument with a 4.4 French catheter. So by changing the way of cannulation with a short wire system using the Endoscopist controlled wire technique, we can potentially limit or reduce the risk of our total endoscopic complications. There's potentially one bias from my point of view. The risk of a total endoscopic complication rate of almost 70% is quite incredibly high. The more clinical data say that we encounter a risk of more or less 3.7%. There's potentially one bias within these data that should be or should have been further evaluated. So to summarize, the criteria of the short wire based on data and based on my own experience, we have a stable access with a guide wire to our target area. From the endoscopist point of view, we have more control over the instrument and the guide wire. That makes the whole procedure quick and easy, and that, I think, can contribute to increasing the patient safety of our patient undergoing an ERCP.
Okay, Mark, thank you very much for this very nice lecture. So the message I take home is it's 6 minutes in colonoscopy and it's 9 minutes in ERCP, isn't it?
Yeah.
With
that's the 9 minutes. That's the big difference. That's the difference of bacteremia, and that's the difference between long and short wire. Yeah.
Yeah, with the notable difference that you should slow down in colonoscopy and speed up in ERCP. So we get the message, but obviously speed decreases the risk in the 2 main aspects, right?
Yeah, you're absolutely right. So it speeding up the whole procedure increases or decreases the risk of cholangitis and bacteremia, and decreases the risk of the post-ERCP pancreatitis. Yeah, you're absolutely right.
Okay, one thing maybe we could discuss a little bit more in detail, which does not have directly to do with the short wire system. It's the other measures we are commonly advised to do to reduce the pancreatitis. So it's NSAIDs and it's stenting. So what do you do in your clinical practice? Everybody, difficult cases. So can you guide us a little bit in that respect as well?
So we have 2 different groups of patients. The one patient group in ERCP is the patient with the naive papilla, so the uncut papilla, and the other patient group is the pre-cut papilla or the stent exchange. So they had already had a sphincterotomy. In every patient, our clinical practice with a naive papilla, we put in NSAIDs to reduce the risk of post-ERCP pancreatitis. We put in rectally 100 milligrams of diclofenac to reduce the risk. So that's the one thing. And then the thing is prophylactic stenting of the pancreatic duct. Only access to the pancreatic duct once is, from my point of view and based on the guidelines, not an indication, but as soon as you're in the duct twice, or as soon as you have contrast in the pancreatic duct, you should put in a prophylactic pancreatic stent, 4 to 5 French with a length of 4 to 5 centimeters, and take that stent out after 5 to 7 days.
Okay, so that means given you have a naive papilla, NSAIDs for everybody, and stenting for if you do longer manipulation, and especially contrasting of the pancreatic duct.
Yeah.
Okay, good. So that's a simple advice. Speed up, NSAID to everybody with a fresh papilla, and selected cases stenting. Well, Mark, maybe at the end of this very nice interview, you could show us a clinical case to round this discussion up.
Yeah, sure. So the case I brought is implantation of a self-expanding metal stent in a benign indication. That was a patient, a 73-year-old male patient who was referred from another hospital with jaundice, recurrent abdominal pain, predominant in the right upper quadrant, radiating to the back. In the medical history, you can think what the patient has. He has a chronic alcohol and nicotine abuse. He has a known liver cirrhosis with a Child-Pugh grade A, with a coronary heart disease and a cold gold stage 3. So we performed an abdominal ultrasound and found a chronic calcifying pancreatitis with the distal CBD structure and a cholestasis, and that's why we had the indication of an interventional ERCP, and that's the case. So the SEMS in a benign indication. In this indication, of course, a fully covered self-expanding metal stent, and that's the video. You already see the locking device in place. So every short wire system has two things in common. It's locking of the wire and splitting the wire from the instruments. So as usual, you just forward your instrument, and as soon as the instrument is in place, the assistant splits the wire from the instrument, and in this S-shaped locking device, you can easily lock the catheter. And that's the first contrast enhancement. You see this dilated proximal 2/3 of the CBD with this high-grade stricture of the distal part, and you already see all these calcification under X-ray of the whole pancreatic parenchyma. The next step, because it was a very high-grade stricture, I dilated the high-grade stricture with a balloon, in this case up to 8 millimeters in diameter. And then to keep the stricture open, we put in a self-expanding metal stent, a fully covered self-expanding metal stent. It's compatible with a short wire, so the wire comes out after approximately 30 centimeters from the distal tip. Then you can easily, along the fixed guide wire, you can easily forward the whole implantation system. You relock the wire into the place where the system needs to be. That's the view through the shaft of the system, and then it's positioned into the proximal part of the CBD. That's the proximal, the middle radiopec marker. That's the proximal tip. There it is. That's the proximal part of the stent, and then you can easily deploy the stent, and that's you unlock the stent by drawing this little screw, and then the system is fixed. That's what I recommend in front of the belly of the assistant, and then just retract the shaft and just keep the whole system in place. Then you do not dislocate the whole self-expanding metal stent. And then millimeter by millimeter, just by endoscopic visual control, I don't need any X-ray in this situation. You can easily deploy the stent and you get this little movement. And then that's the deployment under X-ray. That's the proximal third that is deployed. These two radiopec markers indicate the middle part of the whole stent. That's the proximal part of the deployment system. And then in the end, the whole system, the whole self-expanding metal stent is in place. And then when it's completely opened, you can easily just remove the implantation system, and then you see the drainage of the bile and a bit of pus in this case. And that's the self-expanding metal stent properly in case. In this case, we rescheduled the patient after 6 months. Then we took out the self-expanding metal stents, and fortunately in this case, the stricture completely vanished, and now it's under pure clinical control, and that's the case.
Yeah, thank you very much, Mark. This was an impressive case, certainly within the 9 minutes, for sure. And I think we learned a lot. Please think about short wire techniques, their advantages. Of course, some nurses tell us, well, what do we have to do? But I don't think that's the issue, Mark. As a final question,
Yeah.
Did your nurses appreciate this technique readily?
Yeah, that's exactly the question the colleagues raised when we changed from the long wire to the short wire system. That was meanwhile around about 7-8 years ago. They all said we do not have to do anything anymore, but be sure they are still busy and they still have plenty of work.
And they're still happy, I guess. I know.
Definitely.
I
And
know some of
nowadays
your.
they do not want to change backwards to the long
Yeah,
wire.
I know some of your nurses. They are very nice and very competent. So, thank you very much for this lecture. And ladies and gentlemen, that's the end of our interview. Please join us next week, June 4, for Endoscopy on Air, 12 hours starting at 9 o'clock in the morning of fascinating live endoscopy starting in Australia and ending at the American West Coast and in South America. Mark, goodbye and thank you very much again.
Goodbye, Thomas. Thank you very much.